Hello and welcome. Good evening, and thank you for joining us for our TIF Talk Tuesday. We are very excited to have a special guest, Dr. James Bardoner. Thank you so much for being here, Dr. Bardoner.
Very glad to be here. Thank you for having me.
Thank you. As a reminder, my name is Andrea Millers and I'm with Endogastric Solutions, and this is a live event. So at any time, if you'd like to ask Dr. Bardoner any questions, please feel free to type them in the comment section and we will do our best to answer any and all of the questions that we can today. But before we start, I do want to give a little bit of background on Dr. Bardoner. After graduating with a BS in computer science from Clemson University, Dr. Bardoner realized that he was being called into healthcare. He earned his MD degree at USC School of Medicine in Columbia in Greenville, South Carolina, and then trained in surgery at East Tennessee State University. He enjoys all areas of surgery, and he actually is located in Augusta, Georgia. Again, thank you, Dr. Bardoner, for joining us this evening. I know we're very excited to have you here, and the people that are on or watching are excited as well.
Well, thank you again.
Fantastic. So let's go ahead and start. We're here to talk about GERD and the TIF procedure. So I'll let you kind of start us off by explaining what GERD is and what patients that are suffering from GERD, what symptoms would they be feeling or having?
Yeah, so GERD, or gastroesophageal reflux disease, is basically a problem with the stomach not being able to hold on to what it ought to. And the way we were designed is that the esophagus kind of propels anything you're swallowing down into your stomach. And then there's a little bit of a tapering and a slight angulation, and then a little kind of a sphincter muscle that opens and closes there at the bottom of the esophagus that holds everything in the stomach, even though it's churning and squeezing and generating all kinds of pressure down in your belly. The stomach does that to move things around and help with the digestive process, and there's a lot of acid intentionally secreted in the stomach. Gastroesophageal reflux disease means that some of those stomach contents are getting back up into the esophagus, despite all of the mechanisms in place to try to keep them confined to the stomach. And that can be damaging to the esophagus. It can also, the vapors of it, even if there's not actual liquid getting as far up as the lungs and the trachea, the vapors from the acidic reflux can also be damaging to the lungs and the airways. So I say what GERD is usually misery for whoever has it, but it's a process where things just can find their way back out of the stomach, which is not how we were designed to function.
Right. And, they often talk about typical and atypical symptoms. Can you explain kind of the differences between those kind of symptoms, if you don't mind?
Yeah, so when people talk about typical, I mean, if you think of acid and what would go along with it if it were someplace where it's not supposed to be, those are usually the more typical symptoms of, burning in your chest, sometimes an aching discomfort. It tends to be more present after meals, or if you've been lying supine, because if you've been lying flat, because it makes it easier for things to find their way up out of the stomach. You can also see more atypical symptoms, and those tend to be not as obvious. So it can involve the lungs with frequent coughing, throat clearing, hoarseness, again, because those vapors can be very irritating to the vocal cords and to the lungs. Sometimes people will just have dysphagia, again, because the esophagus can get irritated, and dysphagia meaning that food doesn't go down easily when you swallow. And so it can feel like it's getting caught in your throat, or that you're just having a hard time getting the food to go down into your stomach.
Right. And, we get a lot of questions from patients asking the differences between GERD and LPR, or, what is the difference of LPR, if you don't mind explaining that.
Yeah, so gastroesophageal reflux, we already touched on. LPR, laryngopharyngeal reflux, just means that something is getting as far up as the thoracic, or the inflow to your windpipe. So normally, air and food obviously go through the same hole for a little bit, but then the trachea, which is what heads to your lungs, splits off towards the front of your body, and the esophagus, which is what goes down to your stomach, stays more posterior or towards your spine, towards your back. If you get acidic vapors or, heaven forbid it, actual gastric contents, whether it's acid or food or whatever else, as far up as the level where the trachea splits, that can be very irritating to the vocal cords and to the larynx, which is the very upper part of the swallowing system.
You oftentimes get patients complaining of losing their voice or even singing. I've heard a lot of patients who've not been able or lost their voice and haven't been able to sing because of their GERD and LPR, if you will. Can you talk to us a little bit about what I know when patients see you as a general surgeon, they're probably already along that path where it's really bad, but prior to, or maybe not, I don't know, maybe you can tell me, but what do you generally recommend patients to do to manage their GERD symptoms kind of initially before even medical therapy and then eventually surgical therapy?
So I always tell people I'm a surgeon and I try not to operate, because if it was me, I wouldn't want surgery, honestly.
Right.
So I focus more on conservative things, and it'll depend on how severe it is. And sometimes I have people come in and they're just miserable. And if I give them a questionnaire of how bad their symptoms are, they are at the extreme wrong end of it. And so for them, I don't torture them with things that I don't think are going to work. But for more mild, manageable disease, especially if it's just occasional or with certain foods, I tell people, number one, pay attention to what you're eating. Mm-hmm. So there are certain foods that are going to make you more prone to having reflux. Anything that's got a lot of meat content or fat content to it, the stomach can actually sense what you are eating. And if there is a lot of what we call lipids or fats or proteins, you need a lot more acid to help break that down into the small little molecules that your body can absorb. And so your stomach will dial up the acid in response to that. So I tell people, avoid fats, avoid excessive amounts of meat. You can eat smaller meals, and just a little bit closer together rather than a bunch of big meals spaced really far apart. Stay upright for at least a few hours after you eat. Don't eat in your bedtime, because as soon as you lie flat, there is again all that pressure. And if you've got a full stomach anyway, then it's just going to ask for problems.
Yeah, right. Can you talk a little bit about medical therapy before we talk about different options for GERD? Let's talk about medical therapy and taking, all of, whether it's PPIs or Tums or, antacids. Can you talk a little bit about what that does and how it works?
So we don't have pills that will stop reflux. We have pills that will try to make it so it's not as bad when it does reflux. So nothing's going to actually eliminate the reflux, but there are two kind of broad categories that you can think of. Things like Tums, Maalox, Pepto-Bismol, things like that will go into your stomach and try to bind some of the acid or provide a protective coating so that it's not as damaging to the body. And then when you talk about H2 blockers like Pepsid, or there's the proton pump inhibitors, which have been around, I think, since the late 80s, both of those types of drugs act directly on the stomach to try to minimize the amount of acid that it secretes. So you can either try to sop it up and provide a barrier, or you can try to eliminate the amount of acid secreted in the first place. Both of those later two options have been kind of the mainstay for medical therapy here lately, particularly the proton pump inhibitors. And again, they work on your stomach to cause it to make less acid, so that whatever gets out of your stomach is closer to a neutral pH and hopefully not as damaging.
Yeah. And interestingly enough, I was on a TIF Talk last week, and the physician said that there's no medication to stop regurgitation. And I think that's a big complaint that a lot of these patients have, is the regurgitation. Can you talk a little bit about that and why the medication does not help that?
So the I mean, again, the problem with reflux is it's a structural problem. Normally the esophagus comes down and takes a little bit of a turn as it goes into your stomach, and the stomach, normally the stomach is kind of wrapped around the esophagus just a little bit. It's kind of shouldered up on it so that it makes a long flap valve, meaning it's a lot wider at the top than it is at the bottom. So if you've ever seen like an Inuit fishing basket or something like that you put in a stream, it's really easy for the fish to swim in because it's really wide at the mouth, and then it's very tight down at the bottom, so it's hard for stuff to get back out. We don't have pills or exercises or therapy that we can send you to kind of recreate that normal anatomy down there at the lower esophageal sphincter. So the best we can do is kind of Band-Aids and try to make it so that what does come back out, if it comes back out, is less damaging to your body.
Yeah. I like that analogy. The fishing basket. Doctor last week mentioned the ice cream cone. I was like, oh yeah, that makes sense.
Yeah, it's fun.
Yeah. So talk to us a little bit about, the different treatment options for GERD today. I know obviously we're going to talk about TIF, but there's, the NISSAN fundoplication and so on and so forth. So if you could talk about that, that'd be great.
So the broad categories, I think of three. There's always the conservative things that patients can do on their own. We kind of touched on that. So, staying upright, not eating big, heavy meals. There are also certain substances you can avoid, like alcohol, nicotine, chocolate, menthol. All of those cause the lower esophageal sphincter to relax. One step up from that would be medical therapy. So again, there's the Tums, Maalox, things like that to kind of absorb or help buffer the acid. And then there's the H2 blockers and the proton pump inhibitors. So if you get beyond that and you're looking at procedures, there are surgical procedures, and a significant proportion of reflux is also due to having what's called a hiatal hernia. So there's a muscle called the diaphragm that separates the lungs in the chest from the belly. There has to be a hole there, but it's normally a fairly tight hole so that your esophagus can pass through from your mouth down into your belly. But if you have a hiatal hernia, that means that hole has been stretched a little bit, and it can actually allow part of your stomach to slide up into your chest. So if you have that, then we would have to repair that in order to have any hope of really controlling your reflux. And surgical procedures for that, obviously you fix the hernia, and then it's a question of what do you do about the reflux. So you can do what's called a NISSAN, where they do basically a full wrap and tie the stomach around the esophagus. And I think it had to have been some kind of a mad scientist or someone who was high. I'm trying to imagine who came up with the idea of I'm just going to tie the stomach in a knot around the esophagus. It came about in a time, I guess, when we were a little bit more cavalier about surgical techniques and developing them. But that's literally what you do. If the esophagus normally comes down into the stomach, you take the stomach from one side, pull it around behind the esophagus, and then suture it to itself in front. That is a very non-selective way to increase the pressure there so that it's harder for stuff to get out of your stomach. And that's what we want, is to keep things in the stomach. But that also means that it's harder to get things in the stomach in the first place, because it's not selective. The pressure is always increased, whether you're swallowing or refluxing. And it can lead to problems swallowing, things getting caught in your esophagus. And the way it aligns the fibers of the lower esophageal sphincter is not how it was designed to work. And so it doesn't, I don't like it. I've actually quit doing it. There's a lot of papers that show that it's no better than another technique called a toupee, where you do just a partial wrap of the stomach around itself. Again, it's not a selective way to address the low tone at the lower esophageal sphincter. So it still has the chance of dysphagia, although it's very, very low.
Yeah. So, go ahead.
So those are the surgical wraps. There's also a technique called the Lynx procedure, where you implant magnets into the esophagus to try to help. Again, all of these focus on increasing the pressure there at the lower esophageal sphincter to help keep things in your stomach. I don't necessarily like the Lynx because it's a magnet. It's a metallic object right there to your esophagus, and so they can put pressure in places and causes it can erode through into your esophagus, basically. It's kind of like having a bed sore at the bottom of your esophagus from all the pressure from those magnets.
Thanks.
It's also can be unfun, I'll say, to try to retrieve those.
Gotcha.
And then there's the TIF.
So perfect segue. Why don't you explain to everybody what the TIF is? What does it stand for, and how does it work?
Yeah. So it's the transoral incisionless fundoplasty, and you have a very, I think, sleek, well-designed device. I didn't design it. I'm not patting myself on the back, but I like it. Where it will slide down your esophagus into the stomach, and it goes in straight and then will bend back on itself. And the idea is that it's just going to kind of roll the stomach back up around the esophagus like it was originally designed to be, and help recreate that long segment flap valve. So normally if your esophagus is coming down, the stomach is kind of hugged up around it a little bit, but with increases in abdominal pressure, whether it's from obesity or from just repeatedly eating large meals or whatever it is, you can damage that sphincter so that instead of the stomach being up around it, it's more like a ball, which is your stomach, with a straw stuck in the top, and it just comes straight down in it. And you can see damage of that valve so that it doesn't function as well. The procedure, like I said, helps slide it up, and then you fire fasteners, which are made of a dissolvable polymer, so that there's nothing permanent left behind. They do dissolve over the course of months, and your body will replace them with scar tissue to help put things back the way they ought to be. It can be done with no cuts on the abdomen, as long as you have smaller than a 2-centimeter hernia, and in and out same day.
Right. So we get questions a lot about the concomitant procedure. Maybe we can explain that a little bit. You did talk about the hiatal hernia and then doing the TIF procedure. We get questions as to, well, can I just get the hiatal hernia fixed and not get the TIF, or can I just get the TIF if I have a hiatal hernia, and will that actually rectify my situation? Can you discuss why that's important most of the time to fix both, or not, why we can fix one and not the other?
Yeah. So again, as long as your hernia defect is smaller than 2 centimeters, and if this is your diaphragm and you've got a hernia, so it's a hole letting something slide up into your chest, you can have part of your stomach vertically up in your chest, or you can actually have a 2-centimeter wide hole. As long as it's smaller than that, meaning there's not too much in your chest and the hole's not too small, the TIF is all you would need. And again, it basically just recreates that anatomy to help kind of anchor the lower esophageal sphincter and that junction between your esophagus and your stomach down in the belly where it belongs. If you do have to have surgery for a hiatal hernia repair, you don't always have to have a fundoplasty or a fundoplication after it. It depends on what the sphincter looks like. It is, I would say, exceedingly rare, though, that that's the case. And the reason is, again, if you imagine a hole as it progressively enlarges and it lets more things slide up into your chest, it's very easy for the stomach to get stretched or almost kind of sheared as it, as things are getting pushed into your chest. It tends to damage that valve there. So that instead of being wrapped up around it, it kind of slips off as it slides up into your chest.
Right.
So the first step is fixing the hiatal hernia if you do have one larger than 2 centimeters. And then what type of approach you take for the fundoplasty after that depends on the surgeon. The goal is to get the junction between your esophagus and your stomach easily back down in the abdomen under no tension, so there's nothing trying to pull it back up in the chest. And then once that defect has been tightened, you could do a TIF, you could do a NISSAN, you could do a toupee, you could do nothing as long as the valve looks good. But again, it's very rare that someone would have a competent valve there after having a decent size hernia.
Right. Perfect. Thank you for explaining that. We do have a couple of questions that have popped up, so we're going to try and get through those. Someone's asking, they're taking omeprazole for a lifetime. Is it not damaging to my other organs?
Yeah, so there are a lot of studies that show long-term risks. In general, with the PPIs, if you are going to prescribe them as directed, you're supposed to use just short courses of them. So no more than 6 weeks if you have pretty bad esophagitis. I think the box will actually say 2 weeks, no more than 3 times per year. Sometimes we'll go beyond that for very specific health conditions. But there are, I would say your bones are the main organ that they're at risk for damaging because it can lead to osteoporosis. And again, it stems back to they neutralize acid. You have to have acid to properly digest and absorb what you're eating. So you don't break down proteins as well. It can lead to anemia, osteoporosis from impaired calcium absorption. There's increased risks of pneumonia. And again, all of this is because you don't have acid like you're supposed to. So the iron can't be absorbed as well because of something called intrinsic factor, which requires stomach acid to be absorbed. And then if you think of your stomach as kind of like the doorway to your intestines, there's a defense mechanism also involved with the acid. The idea is that if there's any bacteria or if you're eating something that is maybe just a little bit past its expiration date, things like that, the acid will help kill those pathogens before they can get to the rest of your body. So there has been documented, it's called small bowel bacterial overgrowth. If you have neutral pH in your stomach, you get all that stuff farther downstream in your small intestines. In the intestines, your colon is used to having lots of bacteria, not a problem for the colon. The small bowel doesn't generally have much bacteria at all, and so you can get a lot of bloating and discomfort. We call it dyspepsia, but that's all been a known side effect of the PPIs with chronic use.
Interesting. Okay. And then another question. This is from Derek. He's saying some docs say that TIF is reversible and others say that it isn't. Which one is it? Which one is it? If it needs to be can it be undone, basically?
So I suppose you could go in there and reverse it. I've never seen a need to. I'm not aware of anyone who would need to try. Usually when we talk about reversing a fundoplication, it's because of the terrible side effects. So you'll see that a lot with a NISSAN, a toupee, a door, any of those fundoplications where people basically just can't swallow afterwards because of dysphagia. And so we do reverse those, or I reverse those on occasion. So I'll say, I can't imagine why you would ever have to reverse a TIF because it doesn't have the side effect profile with those other procedures. And then if you had to, it would be doable, but it's kind of an ordeal. So you'd have to basically cut through the scar tissue to unwrap it off of the esophagus. And again, we do that routinely for the other procedures. I can't imagine why you would not be able to do it for a TIF.
Right.
I've never had to do it. And I can't imagine why you would need to if you're not having the side effects of these other procedures.
Thank you. And question about post-op TIF and hiatal hernia, the combined procedure. What does that look like? What do patients have to do, post-op? Everyone talks about the diet. And I have questions on here about exercise limitations. Can you talk a little bit more about what they can expect post-op?
So the thing about the TIF is you do have to baby it a little bit while it's healing. And when we were securing the wrap, you're using these little plastic fasteners that look like what holds socks together when you buy them from the store. And they're not very long. It's a short segment, just a centimeter or two that's anchoring that wrap in place. And we'll use a lot of them to help kind of evenly distribute the tension. But what you don't want to do is stress that too much early on in the post-op process while it's healing. And that stress can come from swallowing big food boluses too soon before it's ready, or from putting too much pressure on it before it's really had a chance to scar in. Mm-hmm. So exercise, I tell my patients, don't lift more than 20 pounds for at least a month after surgery. Again, because if you really engage your core and put a lot of pressure there, you can pop those fasteners and shear them off. Mm. And then I say it's funny because people tend to complain the most about the diet, but then also they really enjoy the side effects of the diet. What I mean is, it's 2 weeks of just liquids, then 2 weeks of pureed like baby food, 2 weeks of soft solids, and then at 6 weeks you finally get back to eating whatever you want. So it is more of a process on the diet, but even though I have people complaining about the diet, they all say, I love that I've lost 15 pounds. And I did it to one of my staffers in my office, and she, that was all the kick she needed. She was fluffy, I will say, to begin with, and she's now down to 40 pounds because she's
wow.
Yeah, I mean, and it's not, it's intentional. It's not, it's not anything where she can't eat. She's doing great. She loves it. But it was just that little kick she needed to kind of jumpstart a healthier lifestyle for herself. And so she's been exercising now. She's eating right.
That's great. Yeah. And they say too, right? It's almost like you have to relearn how to eat, chew your food really well, slow down when you're eating and whatnot. Is she able to eat all the foods that she wants now?
Yeah, she eats whatever she wants, and I like your analogy there of kind of relearning, because I grew up, with my parents telling me you've got to clear your plate, and they would give me kind of big portions to begin with. And I think we as Americans especially are taught from a young age to overeat, and so we put too much in our stomach, which is where a lot of these reflux issues come from. So I've noticed anecdotally, I've seen a fair number of people who say that they feel full a little more easily afterwards, and I don't know if that's because their stomach shrinks up during the 6 weeks that they're on their special diet or what, but I tell them, listen to your body, basically.
Exactly. Yeah, listen to your body.
Listen to your body. Chew your food, swallow. Don't eat in such a rush. Give your body time to tell you that it's full, rather than just shoving what you can down quickly.
Yes, we live in that society, right? We're just always in a hurry. We have another question from Deborah. She's asking, how long does a NISSAN fundoplication last?
So the actual fundoplication, it's very rare that would ever go away. They can slip, and that isn't usually a nightmare if it happens. But when most people ask that question, what they mean is, how long is its effects going to last? And the reason I say that is because we know that there's going to be a recurrence by about 10 years. I think 60% of patients will have a recurrence by 10 years, and it's somewhere around 30 or 40% at 5 years. The wrap is still intact, though, so your stomach is still tied around your esophagus. It's just that you are starting to have reflux again, even though your wrap is still there.
Yeah, perfect. Thank you. Another question: are there more possibilities of cancer with GERD?
Yes, and that's another side effect. But cancer, most types of cancer come about because of repeated stress on tissues. So if you smoke, that's harm to your body, and it leads to lung cancer. Well, lots of cancers. Repeated reflux, again, your esophagus just wasn't designed to tolerate acid. Your stomach was. So if you get repeated injury to your esophagus, that can lead to inflammation, and chronic inflammation anywhere in your body can lead to cancer if it happens long enough. So you can see cancer of the esophagus form at the bottom of the esophagus because of repeated acid injury.
Right. Perfect. And a question, I've read that there's shoulder pain might be experienced post-op TIF. Why does that happen, and how long does it generally last?
And I'll say that's not unique to TIF. That's anything that messes with the diaphragm, but there's a nerve called the phrenic nerve that supplies sensation to the diaphragm, and it's not a very precise innervation. So anytime you irritate that phrenic nerve, most people describe it as left shoulder pain, or sometimes it's pain in their neck and shoulders, but it's what we call a referred pain. So anything that messes with the diaphragm down there, whether you have a hiatal hernia repair, a TIF, and NISSAN, any of those things, that happens.
And how long does it normally last on patients?
I worst case scenario that I've read about, I've never seen, but I've seen it, or seen it documented lasting up to months. Most people, it's just for a day or so afterwards, and it kind of eases off. Average, I'd say, is a couple of days, no more than a week.
Yeah, perfect. Thank you. One other question. Zach's asking, can a TIF be performed to fix a slipped NISSAN fundoplication? patient?
It depends on how badly slipped. If it actually is slipped, meaning the wrap is very far up the esophagus, that's probably going to require an operative revision of the NISSAN to take it down and then convert it to a TIF.
Okay.
If it hasn't slipped too badly and there's no hiatal hernia, that's one of the benefits of the TIF is you can redo a TIF pretty easily over another fundoplication. And I've done it over a TIF once I repaired the hiatal hernia that had come back. Or sorry, I've done a TIF over a NISSAN without having to take down the NISSAN once I had repaired the hiatal hernia.
Okay, thank you. And one more question. Can TIF be performed if a manometry shows frequent failed paralysis? Sorry, I'm trying to read it.
Yeah, so the peristalsis.
That's what I was like, I think, yeah, okay. Peristalsis.
Yeah, so food doesn't just fall from your mouth to your stomach. You can swallow upside down, and it's because of that peristalsis, meaning that the esophagus contracts in a coordinated way to help propel food, or liquid or whatever you're swallowing from your mouth to your stomach. There are risks to any procedure. I've not seen dysphagia with the TIF. And again, it's because you're not actually increasing the pressure there at the lower esophageal sphincter. So it's much less likely to end up with dysphagia. If you have literally terrible peristalsis and no contractions, then you may have other issues that need to be addressed before talking about reflux. But the TIF itself has negligible increase in dysphagia afterwards. So if you do have impaired peristalsis, I'd still feel comfortable offering a TIF.
Perfect. Thank you. And then does TIF resolve your LPR symptoms, especially the breathing and burping part?
Yeah, anything that's due to the reflux, the TIF fixes. It fixes the reflux, it fixes the symptoms.
Fantastic. All right. Well, that is all the questions we have today. Before we, conclude in the evening, is there any that you would give to these patients that are suffering from GERD, whether they're on PPIs for many years or just starting PPIs, and or continuing to have, really bad symptoms from GERD? What would you recommend for them to do?
I tell everybody just kind of think down the road, basically, because we have a lot of providers, particularly GI doctors in the U.S., who will keep people on PPIs long term, and it's just kind of a Band-Aid. It's not addressing the problem. It like I said, it neutralizes the pH, but it doesn't stop the reflux. And there are long-term risks to the PPIs. There's also long-term costs to the PPIs, as opposed to something that you could have done and then be done with it. So
right. Yeah, perfect. Be your own advocate is what I always tell patients to do, right? And if it's not the answer you don't like to hear, then maybe do more research and find someone that can give you different options for treatment of GERD. Well, I can't thank you enough for joining us this evening, Dr. Bardoner. I know we really appreciate it. I know the patients that are watching appreciate it. And if you're in the Augusta, Georgia area, did I say that right? You're in Augusta. Yep, you can look up Dr. Bardoner and find him. But if you're not in the Augusta, Georgia area or somewhere else, and you can go to gerdhelp.com. We do have a physician finder on there, and you can put in your state or your zip code, and you'll be able to find a physician, a TIF trained physician near you. Well, again, Dr. Bardoner, this has been fantastic. I really appreciate it. Thank you so much for joining us this evening, and we'll definitely catch everybody on our next TIF Talk next Tuesday. Thank you and have a great evening.
Thank you.